Hello, everyone, and welcome. While we have a few more people logging in, I just thought I'd take a moment to introduce myself. My name is Alicia Lord, and I'm here as the tech coordinator for today's session. If you have any questions, please put them in the chat. We will have a discussions part of the webinar later, so you can ask questions to the presenters today. But if you have any issues hearing anything or seeing your screen, please do let me know in the chat and I'll attend to those separately. We'll get started here in just a minute and I'll turn it over to Grace. All right, it looks like everyone is here. Grace, would you like to go ahead and get started with introductions?
Sure thing. Hello, everyone. On behalf of all the partners of the National Elder Abuse Training and Technical Assistance Center, I warmly welcome you to this webinar on working with complexity in E-MDT meetings. I see many familiar faces across the teams we've been working with, and some new faces who I imagine are coordinators or members of the various teams. So welcome one and all. The National Center has been in operations now for 4 months. It's been an extremely meaningful period for all of us involved with the center as we work to stabilize our processes, but more critically, as we've gotten to know all of you and your teams much better. We're extremely grateful for your generosity of time and patience as you've engaged with us, helped us better understand your strengths and needs, and really paved the way for us to evolve and learn as a center, figuring out ways to be useful to all of you. So our collective interactions thus far have really led us to this moment where we're happy to be able to kick off our webinar series to provide more regular training opportunities to enhance knowledge levels of all things E-MDT. We already have several other webinars in the planning, ranging from forensic accounting to specialist consultants and confidentiality, so please stay tuned for our publicity. But coming back to today's event, we've heard many of you raise pertinent questions about the issue of complexity and risk, and thought it would be a great idea to bring together 2 experts in the field working with these issues. One as a researcher, Julia Rowan, and another whose work as a coordinator is all about working across complexity and making hard decisions around case discussions and interventions, Khi-Lynn Johnson. Alicia will introduce them in greater detail in a minute, but I will just say that we're very excited to be able to bring them together in what we hope will be a great learning exchange for all of us. I want to also acknowledge that this event and the center's existence fundamentally is made possible through funding from the Office for Victims of Crime in the Department of Justice. And we're ever grateful for the great partnership we have had with them, particularly through our work with Laura Ivkovich, our program manager. As we kick off this webinar series, we're also grateful to have with us a very special guest from OVC to open the session, Bill Wolf, who's the Senior Advisor for Victim Services and the Human Trafficking Program. Bill has been with the Department of Justice since December of 2019. In addition to overseeing OVC's Human Trafficking Program, Bill oversees the implementation and marketing of DOJ's National Elder Fraud Hotline, which OVC administers. Bill began his career as a police officer, was promoted to detective, and assigned to work on the Gang Investigations Unit, where he worked in partnership with other allied professionals in Virginia to address victim needs and to bring justice to victims of human trafficking. So Bill knows the value of informal collaborative partnerships and working with task force members to ensure justice is served. In 2018, Bill received the Presidential Medal for Extraordinary Efforts to combat trafficking in persons for his efforts. Bill is also an adjunct professor at George Mason University and Mount Aloysius College in the criminology departments. It's my pleasure then to invite Bill to say a few words. Over to you, Bill.
Well, good afternoon, and thank you, Grace, for such a warm introduction. As she mentioned, I'm fairly new to the Department of Justice, just coming on board this past December, and I have to tell you, it's been quite an adventure, but certainly a very rewarding one. And one of the programs that I have been most impressed with during the course of my tenure at DOJ, and in particular the Office for Victims of Crime, has been the efforts to address elder abuse and fraud. And so I'm very thankful to be here today. And on behalf of Director Hart and the entire Office for Victims of Crime, I would like to express my gratitude to National Elder Abuse MDT Technical Assistance and Training Center at Cornell University, and of course their partners, for planning and hosting today's webinar. I'm thankful for the invitation for Director Hart to say a few words, and she definitely wanted to be here with you all today to welcome all the new grantees and to the very first virtual training under this program. However, this is a very busy week for OVC, as it seems every week is, and this week is also our National VOCA Conference. And so we're, Jessica and I are tag teaming in order to be at both of these important events, but she hopes to participate in one of your next meetings and sends her best wishes for a fruitful training. The New York City Elder Abuse Center at Vail Cornell Medicine embodies the philosophy that collaborative care is the most effective response to elder abuse, and the needs of victims are simply too many and too multifaceted for agencies and allied professionals to work in silos. As Grace mentioned, I experienced this firsthand in my role as a law enforcement officer, and one of the things that made me so successful in the work that I did was the collaborative approach that we took to addressing all types of crime, and really being able to work alongside victim service providers, advocates, other members and stakeholders, really helped to make sure that we supported the victims and then ultimately were able to prosecute the criminals at the same time. So the Office for Victims of Crime grant that established the center and that has been funded, that's funded elder abuse multidisciplinary teams across the country, supports a priority at the Department of Justice to address the hidden epidemic of elder abuse in this country. As you know, an estimated 5 million older victims are abused, neglected, or exploited in the United States annually. At OVC, we're intensely focused on helping them. This year, we've committed $8 million to enhance services to older victims of financial fraud. This includes nearly $2 million to the National White Collar Crime Center for law enforcement training and technical assistance to improve the identification of elder fraud victims and connect victims to available resources. We anticipate awarding another $6 million this year to implement direct victim service projects intended to improve outcomes, minimize additional trauma, and restore safety and security to older adult victims of abuse and financial exploitation. Elder abuse is a priority for this administration, and for the entire Department of Justice. But it's also a deeply personal concern for Attorney General Barr. A few years ago, Attorney General Barr was used as a lure in a scam targeting seniors. His official Justice Department portrait from 1992 was uploaded to various websites alongside text that told people he had special access to government grants, and if that people sent him some money, he would tell them how to get a lot more money in exchange. He started receiving frantic phone calls from people asking why they hadn't received their money. Some desperately hoped that they hadn't been scammed. Others were embarrassed and wanted to know who they could contact for support. Suffice it to say that the estimated $3 billion stolen from America's seniors annually is more than just an abstract number to the Attorney General. That's why he was so pleased to announce the launch of the National Elder Fraud Hotline this March. The hotline, which OVC funds and manages, connects older adults who may be victims of financial fraud with experienced case managers trained to provide personalized support to callers. In less than 6 months, we have already received over 1,800 calls demonstrating the strong need for such a service. And it has truly been an honor of mine to be able to oversee this program and to see it continue to grow through the support of the OVC team and our partners at OVC TTAC. Now it's up to each of you to develop new strategies to improve responses, services, and access for older victims of abuse and financial exploitation. From establishing new processes for your enhanced MDTs to strengthening and enhancing state adult protective services, to engaging forensic accountants and neuropsychologists as team members, including social isolation experts, to conducting needs assessments to keep on top of your members' educational and skills building needs. Your efforts now have the potential to influence future elder abuse multidisciplinary teams everywhere. And you could not be starting this complex work or expanding your current MDT efforts at a more important time. Older Americans are disproportionately affected by the pandemic, but their physical health is not all that is at stake. Isolated from loved ones, they're also more vulnerable to financial exploitation as online scams and other frauds are increasing. As leaders and members of enhanced multidisciplinary teams, your coordinated and comprehensive responses to elder abuse will help ensure that older Americans experience a sense of security, peace of mind, and the support of their community. As I mentioned, it has truly been a pleasure to see this program continue to grow, to see the commitment that you all in the field have, as well as our staff. I'd like to give a special shout out to Laura Ikovic from the OVC team, who has done a tremendous amount of effort and work to support the work that we do against elder abuse and fraud. And on behalf of Director Hart and the entire Office for Victims of Crime, I want to thank you for taking up this critical fight against elder abuse and exploitation. Your work is critical, and if there is ever anything that we can do to support you, please do not hesitate to reach out. We are with you all the way at OVC and can't wait to see all the good that comes from your grant programs. Thank you, and good luck with today's training.
Thank you so much, Bill. It's a pleasure to have you here today. We're going to move on to the first part of our presentation by Margaret Rowan. She's going to give a brief introduction of herself, but she is a postdoctoral scholar at the USC Leonard Davis School of Gerontology. And we also have today Khi-Lynn Johnson, who is Weill Cornell Medicine's New York City Elder Abuse Center's Enhanced Multidisciplinary Team Coordinator. So Julia, can you give a brief introduction of yourself and go ahead and get started?
Thank you so much. Well, you did such a lovely job introducing me. I'm not sure what else I would add, except that I think I've been able to meet with many of you on the one-on-one calls discussing goals, and I just want to say what a pleasure that has been for me in understanding your work. And I think what's important to know for today and as our work continues over the next few years is that my research interests are really around understanding elder abuse, I think from a realist perspective, meaning that there is a way that each of you understand your elder abuse work that you see in a day-to-day way that I think we haven't quite yet captured in our elder abuse research. So that is what we'll be talking about today. And I just want to say, so we'll be talking about complexity. I think Wicked Problems, it's a flashy, fun title, but I just want to say that, so one thing we found in this study is that not all of the elements that contribute to complexity are necessarily problems. So I'll talk more on that later. Next slide. So complexity, this is a really commonly used word in talking about elder abuse. We hear over and over that elder abuse cases are complex, the complexity is increasing, and it is the reason why we have multidisciplinary teams to address the multifaceted aspects of abuse in one room by creating these case plans that look at abuse from all of these different lenses. But here's the thing is that there's not really any kind of objective measure for complex. Like, for example, in the work that you do, you might notice if there are different types of abuse, what risk factors might be occurring, vulnerability in the client, but is there any way to objectively measure whether one case is more complex than the other? We haven't gotten there yet. So this is part of what my research is getting us a little bit closer to. But first, I want to talk a little bit about risk factors to make sure to differentiate. So this might be a familiar graphic. Oh, you read my mind. That was perfect. Thank you. This might be a familiar graphic to some of you. This is the elder abuse intervention model. This is based on risk factors. Now, when we talk about risk factors, what we mean are individual characteristics in either the abuse victim or the perpetrator or their circumstances together that have been proven by research to increase risks that abuse will happen. So what is complexity? Next slide. Complexity is a little bit different because when we talk about risk, we're talking about looking at all the different factors of a case, like the checkboxes that you may fill out when you're filling in a client intake. Complexity is the whole picture. So when we talk about complexity, we're looking at how all of these parts relate to one another. And I believe this definition here on the slide is one that I pulled from the dictionary. And it says it's something that has many different parts and it's difficult to understand or find an answer to. So that's kind of a more holistic view of elder abuse cases. And again, I mentioned the focus is on the interrelated parts. Now, complexity is anecdotally understood, which means we understand it when you hear a story of abuse. In our MDT meetings, when you hear a case, you just know, like, wow, this is a complex case, but there's no objective way to measure it. Next slide. Now, it's said that complexity may or when people talk about complexity, I'm sorry, I didn't mention this on the last slide, but one thing that people talk about is like cognitive impairment, maybe intellectual disability. If there's a case that involves substance abuse in the victim and or perpetrator, that might make it more complex. Legal documentation that people don't understand that need experts to look at, that might make it more complex. But like I said, there's no objective measures so far. So that is the purpose of my research, was to look at what are those different factors that contribute to case complexity. And what I did, so my data came from a multidisciplinary team in Los Angeles that has an added component of a case manager. And that position is called the Forensic Center Service Advocate, which is what the FCSA acronym stands for. And what she does is for cases that need a little bit of extra help, where the victim maybe the team lacks a really in-depth understanding of the dynamics between the victim or the perpetrator, or the victim needs a little bit of extra help. following through with what the MDT decides they want to do to help the victim, that is when she steps in. So ultimately, her cases were the most complex of the complex cases in LA County. So that the LA County MDT sees the most complex cases in LA, and the service advocate gets the tippy top of that pile. So what she had done for each of these cases was transcribed documentation. Each time she reached out to the client, had a conversation, each time she visited them in her fieldwork, and every time she was collaborating with other team members, she took really detailed notes on what was said, who said what she observed, and what was done on the case. So that's the data that I used to do this study. What I did was I and another researcher looked at each of these narratives for 22 cases, and we just went through and coded what were the things that we noticed that were contributing to difficulty in resolving the case. Next slide. And so here's just briefly the characteristics of the sample that we reviewed. So just to demonstrate that this was a very complex group. Average age was 77, most were women, about half were living alone, half had mild physical impairment, and half had moderate to severe cognitive impairment. The most common form of abuse was financial and self-neglect, and almost half had more than one form of abuse. And I think what was really most important that shows the complexity and difficulty of this small sample of cases was that more than half of them were repeat customers with APS, meaning that over the numerous years that they'd come back over and over and over to Adult Protective Services. Next slide. So here I want to just go through quickly the different categories we found. These were all the different aspects of the cases that we felt contributed to the complexity. Next slide. I'll go one by one. So first were aspects of caregiving, and this included descriptions of caregiving that was needed and caregiving that was being attended to. And like I said, we didn't just look at the problems, we looked more holistically at what are the problems and the strengths. And sometimes these were, there were strengths and issues in the same situation, such as caregiving. Next slide. The majority of these cases had issues with health, symptoms and diagnoses. Many had injuries and other physical ailments. Next slide. Now here's another one that we couldn't necessarily say that preferences of the client were problems, but in many cases the preferences of the clients, when they were countering what the service providers were wanting to do, it created some complexity of how to work with the client. So we got some really interesting information about what it is they wanted in life, what services they preferred and didn't, kind of interventions they were interested in. And we did include when they refused help. Next slide. Most of them had some sort of cognitive impairment. We looked at both diagnoses and observations. Next slide. This included mental health symptoms. Next slide. So we looked at both for financial aspects of the case. We looked at people who were low income, who needed help with their finances, and also those who needed financial oversight. Next slide. So health and community services. These sometimes were issues in terms of access, the client getting access to services, and also poor quality of services. Next slide. We also looked at any issues that were related to socialization, which included isolation and issues with family members, as well as individuals that were providing some sort of social support. Next slide. Oh, here was interesting. So you would assume, and in these cases, all of them did have safety issues occurring, but there were also safety issues that were outside of the elder abuse. For example, you know, people who are cognitively impaired doing things like walking out in the middle of the street, or approaching strangers, or engaging in behaviors that made them vulnerable, not just to elder abuse, but to other types of harm. Next slide. Housing was an issue for half of the cases that we reviewed, such as conflict with neighbors, housing instability. Next slide. Transportation was a big deal for a lot of them as well. Some people had driver's licenses and weren't able to safely drive, but were still doing so. And some of them were losing driver's license, which made them, it was a problem for many people, making them vulnerable to assistance from unscrupulous others. Next slide. Many had caregivers, and we coded separately caregiving need from issues with the caregiver or aspects of the caregiver themselves, because they appeared different. Not all of the people who had caregiving needs had caregivers, for example, so we looked at those differently. Next slide. And of course, there is the abuse. All of them had some form of abuse that put them into the services of the service advocate, but there was also abuse that was discovered through her work that was, for example, long-term, maybe, or some of them did actually have abuse as children. They were victims of child abuse and domestic violence before they had become older adults. And some of them had abuse that occurred after the service advocate's involvement began. Next slide. Okay, so what we found was, of course, these cases were super, super complex. Like I said, they were the tippy top of the complexity pile. But what this allowed us to do was to really look at a broad range of issues that are co-occurring in cases of elder abuse. And it allowed us to look at what happens in attempting to resolve elder abuse when you have all of these outside factors. What was interesting was that a lot of these issues were long-term. I'm sure this is something that all of you see in your cases, that there are health problems, family conflict, histories of poverty and abuse that have been going on for decades. And that does create real challenges when you're working one-on-one with a person trying to help them. And I think maybe one of the most important things in terms of complexity is that a lot of these factors were mutually exacerbating, meaning that they were making each other worse. For example, people with behavioral health symptoms and cognitive decline had challenges paying their bills, which compromised their housing stability and their ability to transport themselves, to run errands, and to socially connect with other people. All of those things impacted one another. We found that in every single one of these cases. So to me, that illustrates that you can't really just zero in on one aspect of which is elder abuse when there are so many outside problems, that it really is important to look at the whole picture, which all of you do. But what happens when you're trying to evaluate your program, or when you're allocating resources for elder abuse specifically, but you've got all of these outside things that are needing to be addressed concurrently? Next slide. Okay, so Khi-Lynn is going to help us out and flesh this out into what this means for you as you're looking at your MDTs. And I just want to say, the last thing I'm going to say is that, again, all of you who are in this meeting are the experts because you work one-on-one with victims. And so really interested to hear your thoughts on how this lens would affect your teams. Looking forward to that conversation. And that's it for me. Thank you.
I'm going to play off of what Julia stated with her title slide, is that we just kind of come up with creative ways in which we can kind of title our slides. So to E-MDT or not to E-MDT, complexity is the question. I would be remiss if I didn't mention elder abuse and the types of elder abuse when thinking about complexity and how we address these concerns when thinking of bringing cases to our team. So again, when abuse co-occurs, these heighten the risk factors and definitely speaks to the complexity of our cases. And if there are cases where there's physical, sexual, verbal, psychological neglect and financial exploitation taking place, again, it brings a heightened risk factor when thinking about bringing a case to an E-MDT. Next slide. So when assessing what makes a case complex, we definitely want to look at all of these factors. And again, having one or more of these factors, I would say would mean to me, this case definitely needs to come to an E-MDT. So when you're thinking of two or more systems being involved in a case, I can think of cases where we might discuss with the elder abuse program a particular case that they may have, and they may say within a consultation or a discussion that Adult Protective Services is involved, and the victim hasn't seen their doctor, and the victim, came to their program because she received an eviction notice and didn't have knowledge that she was facing eviction or that there was any issue with rental payment. And so what that means for me as a coordinator is that multiple systems are involved here, because we're thinking about Adult Protective Services being in place, the elder abuse program who's talking to me right now, possibly that this victim has to go to eviction or housing court, and then also thinking about maybe the bank that this older adult is working with in order for them to rectify this issue or this concern. And then I'm also thinking of what specialized expertise may be needed for this case when talking about, the banking issues. We might want to get the forensic accountants involved. I mentioned that this elder abuse program might state that the victim has not seen a doctor in a long time, so we may also need to get the geriatrician or geropsychiatrist involved in this case as well. And so, you'll see listed on here some of the ethical issues, and sometimes people don't, think about ethical issues when it comes to the complexity, but it seems that it's difficult when there are multiple systems involved. Who takes responsibility for this case? And I think that's something that I definitely consider when bringing the case to the E-MDT is how do we spread a plan to be able to have everyone touch this case, as well as for everyone to work together towards a common goal. And so we do that by kind of lapsing the gap in communication between these programs, but definitely taking that in consideration when assessing if this complex case should come to the E-MDT. Next slide. And then additional concerns when assessing complex cases is just if it's known to various elder abuse community organizations or other programs that are involved, an escalated risk of allegations, meaning that we may have a client where there was just in the beginning verbal abuse, and it may escalate to threats, and then may escalate to actual physical assault. And we've had cases like that where we've discussed them with the elder abuse program in the very beginning, where the elder came to their program just to discuss, some issues that they were having on their own. And then these other things were flushed out. And then as we progress, it seems like the elder abuse program has brought the case to our team again, stating that there are other factors. And so we definitely take that into consideration as well, that there has been an escalated, move or escalated allegations to the case when it starts either verbal. Sometimes it also starts with physical, and then we come to learn that there were other things that occurred, and it may be sexual from the very beginning, and the older adult just didn't feel comfortable with, kind of expressing that information. So these are all kind of factors that we take into consideration when assessing if the case should come to the team. And then we also definitely like to look at if this is sustainable for the older adult when thinking about stealing of that person's pension Social Security, their SNAP benefits, and the draining of their assets. The case that I mentioned earlier where the person came in because they didn't know that they were facing eviction, again, we want to have an ability to assess if this person can sustain their lifestyle, if their finances are being diminished, is it at a state in which they can handle? Does emergency actions need to come into play, and how that might transpire within your team? Next slide. So additional complexity concerns, again, with the financial circumstances posing imminent risk, missing doctor's appointments, preventing from attending religious service or social events or senior centers, caretaker and experiencing caregiver burden. And again, that language has changed, at least throughout my career as an elder advocate. You know, we talked about caregiver stress, now it's caregiver burden, but we've struggled with that. You know, do we want to kind of call it caregiver stress or caregiver burden? Because as we see it, these factors can be abusive. And so it's hard to determine whether this is someone's cry for help because they are experiencing caregiver's burden, or if this is a complex issue where there is a time for us to step in and assist, as well as for us to go in maybe with involuntary actions. So again, that adds to the complexity of the case and whether we're going to bring that case to the E-MDT. And then also if the victim has severe health risk. Next slide. And so I always like to kind of give us a little acronym when assessing for cases when we're addressing safety. We want to think about getting that person to safety. So let's drive this car. We want to categorize what types of abuse are occurring, assess for immediate harm, assess for long-term effects and sustainability, and then research members on your team for possible referrals. So what this looks like when the team is driving the car is everyone is utilizing their lens to categorize what types of abuse are occurring. And that may mean the geriatrician is looking at this case differently than a civil legal attorney. And by everyone coming together at that table, we're all looking at this case differently. And so we're able to categorize the types of abuse differently, and we're also able to assess immediate harm differently. And then when we kind of assess for long-term effects and sustainability, that's kind of the financial exploitation piece of some cases, as well as sometimes physical abuse. And sometimes your geriatrician may look at this differently than your forensic accountant. So again, this may mean that our geropsychiatrist or medical team member may intervene by contacting the victim's medical care provider to shift the concern for maybe their medical needs to maybe putting in some emergency services. Maybe they need medication management. Maybe they want to focus on other supportive services that can be completed inside of the home. And then we may have some elder abuse programs that offer shelter to develop a plan for that victim to relocate. And that's why it's useful for us to research members on our team to have an idea of what they can do and what they can't do. Again, and after we kind of drive this metaphoric car, we want to think of how we can park this car. So what that means for the E-MDT is how do we close this case where we have reached out and effectively identified each of the risk factors, and have we developed a plan for each of these risk factors, and have we carried them out to where the victim is no longer in danger, or we have diminished the risk significantly where we feel comfortable in closing this case for the team. And each case is different, but the way we assess each case should be the same, in the way that, you know, we kind of are utilizing one system as a team to address cases, as well as what do we do when there is an emergency. And sometimes for my teams, it means that we act within the team meeting. These calls that a geriatrician or a geropsychiatrist might make may happen within the team meeting time. We've had situations where we developed a emergency plan to relocate right after the meeting, where we worked with NYPD as well as other elder abuse programs to get that older adult to safety until we are able to develop a bigger plan on how we can have them safe in their community or in their home. So again, I think that it really is determined on the coordinator kind of to differentiate whether this is an emergency situation or if we're looking at a safety plan until the team is able to assess a case. Next slide. And this is kind of where we wanted to dialogue and to kind of get questions on how we can really have a conversation about what that may look like for teams and what complexity issues you may be facing in your field.
Thank you so much. So everyone, you should be able to unmute yourself if you'd like to ask questions or you have a comment about today's presentation. You can also put comments and questions in the chat box.
So Shelley Carlson just asked, how do you address these complexities if you do not have those disciplines as part of your MDT? Great question, Shelley. I think I'm going to start answering that just by saying that this work is what we provide are some examples of what we've seen and what's been done at NYSEAC. But it's all translated. It's all up to you, I think, to translate to your individual teams and to inform your lens of how you look at your cases and how you comprise your team. So I think you bring up a good point that if there is an aspect of the case that requires a discipline that you don't have at the team, that it's really important, if you can, to get those organizations at your team. And what I've seen happen is actually sometimes an individual case will be an opportunity to engage an organization that isn't formally a regular member of the team, but to invite them as a discussant for that particular case. I've seen that be a successful approach at engaging organizations that aren't really looking through the elder abuse lens and aren't involved in the MDT. What are your thoughts on that, Khi-Lynn?
Yeah, generally we do invite guests to attend if we feel that someone that has that specialty lens isn't sitting at the team and we feel like we need that perspective. We do invite them to the meeting to give their expertise. But another way to go about, generally reaching this issue is definitely to first categorize what the complexity is and possibly research other elder abuse programs in your area or in your state that may provide assistance. And then sometimes, reaching out to those other elder abuse programs, they might have specialists that sit within their individual programs. Again, the sanctity of the E-MDTs is that we're not working in silos and that we have the ability kind of to reach out to ask for, that assistance if we need it.
Do any of the other participants have any thoughts on that? Anybody want to add to that? So there are a few other questions that have come through the chat box. There was one from Alicia Lord. She was asking, was refusal of services measured as a factor of complexity in these cases? Yes, it absolutely was. And it was aspect of the case that exhibited in almost every single case, actually. That was kind of a focal part of why they got referred to the service advocate, because her approach was person-centered. So that doesn't mean that the cases in the MDT were always that way, but that happened to be one of the deciding factors for why she got the cases, is to try and understand what were the underlying reasons for why they were refusing services, and if there was some way to walk that middle ground between what the client wanted and what the service providers wanted. And that could be a whole other discussion. Feel free to reach out to me if you want to talk more on that. There's some other questions that popped up. Oh, Dina Schwartz asked, can you give examples of some ethical issues that come up? Khi-Lynn, I wonder if you'd want to answer that.
Sure. So some ethical issues that come up for our teams is sometimes there's an elder abuse program involved, and then APS, Adult Protective Services, is also involved, and there may be a banking system that is also involved, and then they struggle with who takes ownership of moving that case forward or who takes ownership of that case. And sometimes what we do is streamline communication to assist with that. And sometimes it also is dependent upon the older adult's ability to be a part of their service plan. Meaning if this person is unable to be a part of their service plan and can't dictate what their wants are, then we may want Adult Protective Services to kind of drive the bus in that scenario, because they can offer involuntary services compared to other elder abuse programs. So it really depends on the policies and procedures of these organizations. And again, we as coordinators don't know every organization's policy and procedures. So we really look to them to kind of let us know what they can do and what their limitations are, and what some of their barriers are, so we can look for a way to engage with all the programs, really to address that ethical issue. Some other ethical issues that come up for our team is what the victim's wants are, and being able to take that in consideration. A lot of social workers really struggle with self-determination, and being able to respect the victim's self-determination and their ability to state what they want and what they don't want. And the issue that we bump against in elder abuse is that they may not want the alleged abuser, if that person is a trusted other, to face any prosecution or punishment in any form. And they may not want that person out of their lives, even if they're harmful to them. So we also have to take that into consideration. And again, it becomes a real complex issue with how do we manage that, and how do we make the best decision or choice for everyone who's involved in a case.
Thanks, Khi-Lynn. I also wanted to add, and related to the question that Alicia asked about victim preferences and refusal of portions of the safety plan, that what we found, the MDT that I work with here in LA County has found that longer term case management and relationship building is the best way to incorporate those parts, to really understand what the person will accept, what the victim will accept, because sometimes what initially they say is not necessarily how it plays out. If trust is built and they understand through the work of a case manager how their refusal or acceptance of services will really impact their lives, that sometimes they will be more willing to accept services that initially they refused. And Linda Howard asks, is there a developed framework for staffing cases in MDTs? Something to keep the team and group on task. I want to ask, Linda, can you tell, when you say staffing cases, does that mean the cases that you select for the MDT case review?
So while we wait for Linda to respond, I can, I guess, tackle Okay, she said yes. We
Thank
meet
you.
bi-monthly and staff. Julia, do you want to take this on, or do you want me to continue?
Continue.
Okay. So when it comes to kind of the framework, not that I know of, but we are constantly developing policies and procedures when it comes to framework of staffing cases and how we assess cases. And I think each team does it differently. At the New York City Elder Abuse Center, we consult on cases prior to bringing complex elder abuse cases to our team, and that helps us with staffing the cases and bringing cases to the team. Some of the framework that we utilize to keep the teams on task, or we ask specific questions that kind of are concerns for the person who brought the case to the team. Meaning generally we want to know, you know, when it comes to the person's medical concerns, how concerned should we be, and what risk factors or what aspects we should take in consideration before developing some of our plans. We also may want to take in consideration some of the limitations when it comes to safety planning and how we do that. How do we engage with the family? And if it's a financial exploitation case, we may also think of questions or concerns with sustainability, and what that may mean to a victim, and what are some ways in which we can obtain documentation or proof that will assist us with assessing the financial exploitation. So again, it really generates off of the concerns of the person who brought the case to the team, but specifically when it comes to framework, there aren't any current policies and procedures with how this is done. And I think that this is something that we're developing. As Grace mentioned, I believe they're within 4 months of them developing, you know, TA for all of the coordinators. And so I think that it's going to be a part of that initiative to develop some of that framework.
Absolutely. I just want to underscore that in terms of framework and staffing cases, each of your teams are different, and you have a different set of people and slightly different missions. And so you get to test for yourself what works for you. And we are excited to see what you learn in terms of your own decision making on staffing cases and how you keep the group focused. Okay, so Joni asks, what were some of the best techniques to build up the referrals to your E-MDT? How are you getting cases in? And did you find that the longer you are in place that the cases got more complex? That's a great question.
So I will say that the best technique is relationship building. A lot of times people feel uncomfortable bringing their elder abuse cases because they may felt that they misstepped or that there's something that they're missing that they're not getting. And so it really takes a lot of trust to bring out a case that you feel, you know, you don't have an understanding of, and you may have messed up along the way to some degree. So a lot of times it took a lot of relationship building to, you know, build up referrals for our E-MDTs. And yes, in the beginning, when it comes to complexity, sometimes there may be 1 or 2 systems involved or elder abuse concerns, and it really took a lot of outreach to really get people involved in the E-MDTs, as well as for them to see what complexity means. And as we continued working with certain teams, with all of our teams really, but as we continued and developed those relationships, we did see that we got more complex cases. People would reach out to us only when a case was complex. And so we weren't getting any of those kind of one-off issues. They were able to, you know, refer on their own to certain services and take certain suggestions and kind of move the case forward without the assistance of the E-MDT. So we were really, as we developed those relationships towards the end, or, you know, as we see it within the last year or so, we're able to really review only complex elder abuse cases in our E-MDTs. And sometimes that does slow us down a bit, but we are able, and we relish in the fact that our teams are growing and they're able to see that some cases are more complex than others.
So what I'm hearing is it's the element of trust among members is so key to people feeling comfortable bringing cases, because I think without that trust and prior understanding, people may be fearful that it will be used against them, or they'll be focused on and made an example of. And what I've seen in the teams that I've worked with is that skillful facilitation is a really key aspect of that. The facilitator has the power to hold a safe place in the meetings to make sure that members and partners communicate in a way that is respectful to one another, and to take it upon themselves to really deeply understand the roles of each partner, and to help communicate that to other individuals if they don't seem to understand it through whatever remarks in the meeting. I'm wondering if anybody else in our audience has any thoughts on that. And either if you want to speak up or throw ideas into the chat box, that would be welcome, because I know that many of you have experience staffing cases, and many of you have MDTs that have been around for a while. And while you're thinking about that, I'll move on to the next question. Bonita Ball asks, how many elders were a part of your research, and were they all referrals in one area? Yes, thank you for asking, Bonita. So the research that I described to you was done in LA County, Los Angeles County. There were 22 cases that were involved in this research. Since this study was summarized, what I've shown you, we've gone over an additional 25 cases, and we'll be publishing on that. The results are pretty much the same. That was same general categories of issues that we found. Are there any other questions and thoughts? Laura Stein asked, will we send the slides out? Yes, those will be available to you. And it looks like this is recording, so that will probably also be available to you. I just wanted to say one more thing about complexity in general. So I'm a researcher. I've never done one-on-one work in the field like all of you have. My first thought when I think about complexity is an evaluation. I know that a lot of you are building in evaluation components to your team, so that you can objectively measure the impact that you are having, that your work is having across all of your clients on average. So here's where I see complexity relating to that effort is, just for example, some of you have more than one team that you're working with. If cases tend to be more complex in one team than another, that might impact how far you're able to get with your clients. And so I think for evaluation, there's some clear implications for how incorporating some measure of complexity, some understanding of complexity when you're looking at the impact you can reasonably have on your cases. But then also, I just wanted to add that on because we're talking right now about, we've been talking about complexity, focusing on individual cases, how you decide whether or not to bring in a case to your MDT, and how you go about working with the case, as Khi-Lynn was describing. Any final thoughts, Khi-Lynn?
I guess my final thought was also to support your statement when it comes to complexity and how your teams may look at complexity differently. I do see that our teams, our rural teams and our city teams kind of operate differently and deal with complexity differently. And there may be an extra layer of complexity for our rural teams because we are dealing with maybe less resources. For New York City, our rural team looks like Staten Island, where we have a limitation of elder abuse programs and possibly other resources, you know, geriatricians or other programs that come into the older adult home that we don't see in our Brooklyn, Manhattan, and Queens teams. So again, that adds to the risk factors, that adds to the complexity of a case. And sometimes by developing the relationships within the team amongst the elder abuse programs that sit on those teams, it also assists with some of those resource issues because they're able to share that information within the team of what has worked for them, what hasn't, and what programs are available in their area for their older adults. So again, you know, I really push open communication and relationships within your teams as well as with, you know, your coordinator.
All right, thank you both for joining us today. Grace, did you have any last minute comments?
No, thank you.
Okay, thank you all for coming. We will be sending out the slides to everyone as well as the recording and a brief evaluation of today's presentation so that we can better serve you in the future. Thank you so much.
Thank you.
Thank you. Have a great day.